Good morning, everyone, and thank you for joining us today for this online session. We are conducting the session on understanding the landscape, current challenges in diagnostic safety. That is the topic for today's webinar. I'm Dr. Ratna Devi, and I represent an organization for Patient Academy for Innovation and Research. We are a patient advocacy organization, and we work on patient safety as one of our verticals. We have been celebrating World Patient Safety Day for the last 3 years consecutively. And this year we have designed a series of 6 webinars, Understanding Diagnostic Safety. To give you a little bit of context on why diagnostic safety, we have heard very frequently about medication errors, surgical errors, injection safety, etc. But diagnostic safety is not a topic that is very often discussed. And this is an area that affects a lot of patients who go to the hospitals. In terms of a different definition, diagnostic error is defined by the National Academy of Medicine as a failure to establish an accurate and timely explanation of the patient's health problem and or communicate that explanation to the patient. And diagnostic error is an increasingly recognized threat to public health, with estimates of 5% of adults being affected in outpatient environment. And in the hospital setting, diagnostic error is responsible for 6 to 17% of adverse events. And this is as per the literature that's available. The Institute of Medicine or the National Academy of Sciences in their seminal report on diagnostic safety concluded that most people will experience at least one diagnostic error in their lifetime. And this is as per an NIH publication. Broadly, there are 2 categories of underlying root causes for diagnostic errors, one being the cognitive-based factors such as failure to detect and learn from errors, and system-based factors such as the lack of provider-to-provider communication and coordination. So reducing the incidence of diagnostic errors is increasingly a priority for both government as well as professionals and philanthropic organizations like ours. However, there are several obstacles to measurement of diagnostic safety, and this has hampered progress towards this goal. Measurement of diagnostic performance is necessary for any systemic effort to improve diagnostic quality and safety. While numerous healthcare performance measures exist, none is being used routinely to assess and address diagnostic errors, and development of diagnostic safety measures is really in its infancy. So diagnostic errors are events that may be distributed over time and place and shaped by multiple contextual factors and complex dynamics involving system-related, patient-related, the healthcare team-related, or even individual cognitive factors. It's a very complex, multidimensional issue. And availability of clinical data that provides the longitudinal picture across care settings is essential to understand a patient's diagnostic journey. Given this complexity, we felt that this is a topic that is worthy of addressing, and we have with us 3 eminent speakers who will be addressing these challenges today. As I said in my opening statement, we will be understanding the broad challenges and the landscape that is there for diagnostic errors. And if I can have the full screen, I have 3 speakers with me today, and it is my privilege to introduce you to them. We have Dr. V. Hariharan, who is a Senior Metrovigilance Associate and Metrovigilance Program of India and the India Pharmacopoeia Commission, Ministry of Health and Family Welfare. And he has more than 11 years of experience in various government related programs and other initiatives led by the government and the National Institute of Mental Health and Neurosciences, Bengaluru, and as MEG technician in the National Brain Research Center in Manisa, Gurgaon. We will follow his address with Dr. Ranjan Agrawal, who will be speaking about, can I have the next slide?
This is next slide, I think. Is it visible, ma'am?
No, it's not. Yes, it is now. So we will be following Mr. Hariharan with Dr. Ranjan Agrawal, who serves as the Honorary Secretary of the Indian Association of Pathologists and Microbiologists, an institution with an acronym of IAPM. He also holds the position of Professor and Head of Pathology at Rajeshri Medical Research Institute in Bareilly, India, and has contributed to the field of pathology and microbiology in significant ways and has been actively participatory in various professional activities. We will follow Dr. Ranjan Agrawal with Dr. Vikram Singh, and he will be speaking about a topic which is what is a harm to healthcare. He's a manager, PhD research, accreditation, and a project manager, BCG Punjab Government Vocational School, and Max Society of Medical Academics, Innovation and Research at Saket, New Delhi. He's also the former assistant professor and HOD Department of Medical Lab Technology, Clinical Research, and PhD Research Program Coordinator, and a research fellow, ex-research fellow at the All India Institute of Medical Sciences, New Delhi. Welcome, sirs, to all of you, and it is our privilege and an honor to have you speak with us today. If I can have the agenda, Keshav. Our first speaker today is Mr. P. Hariharan, and he will be speaking about the regulatory landscape for diagnostics. So, Mr. Hariharan, over to you, and Keshav, if you can help us with his presentation.
Yeah.
Thanks a lot for your valuable insights and giving this opportunity, ma'am. I think it's going connected to the right system. Okay, thank you for sharing this screen. Can you please make full screen if possible?
Hope it is visible.
Yes.
Yeah,
Yep.
you haven't made
Yes.
it full screen. Please make it full screen by going to the right bottom full screen icon. Next to the cursor, which shows the zoom.
I think it is now full screen.
Yes, it is.
Yes, thank you.
No, it's gone back to not being full screen.
It came back from full screen. Okay. By the time being, I'd like to explain. Thanks a lot for the wonderful opportunity and very good morning for everyone. And thanks for giving a valuable time for joining this program. And as Madam has briefed about the diagnosis and its errors and coming up with some other consequences of thing and how the government and other regulatory organizations or other statistical bodies are taking care of necessary actions will brief in this. This content is around more than 2.5 hours of sessions. So I'm trying to crisp to 20 minutes. So I'll try to make as clear as possible. Apologies in case if I'm making it so faster. And slides will explain more than what I'm trying to explain. So I'm trying to design such a way. So apologies in case if I rush off. Can you move to next slide? Myself, V. Hariharan from Senior Material Vigilance Associate from Material Vigilance Program of India, Indian Pharmacopoeia Commission. So our commission is like we have IP, Indian Penal Code. Same way is a law exists in the country. Same way for the drugs, we have Indian Pharmacopoeia. Is a legal document, says what are the standards and procedures to be followed. And we also have National Formulary of India, which tells about the formulation of drugs and its standards. And we also have a reference and impurity standards, which talks about the set of standards and references for the further drug development. Even though the product has a lot of clinical trials from phase 4 to a smaller population to phase 4 of little good population and a lot of studies and analysis is done, still there can be a risk and benefit balancing. So we need to have a post-marketing surveillance, whether with a larger population or the end users or a particular genetical or a particular group of population, whether it is having any effect. So we need to have a monitoring system. So we have a post-marketing surveillance has been initiated by Government of India and Ministry of Health and Family Welfare as PVP and MEPI program. PVPI program deals with drugs and Material Vigilance program deals with medical device, IVDs and surgicals. Not only these are the two programs monitored by IPC. Apart from this, we have some more programs like Chemo Vigilance program for blood and blood products. And we have other drug standards and other programs exist. Can you move to next slide? So this is a general definition of medical device. As per the WHO and as per the medical device rule 2017, any medical device is defined as an instrument, apparatus, machine, appliance, implants, reagents, software or medical products used in combination with any of these for a diagnosis, of preventive monitoring or treatment or elevation of any disease or any compensative of an injury or investigation or a replacement of a particular part or any control or contraceptive or providing information about the mean of in vitro examination for a specific derived from a human body, which can be used alone in a combination for human beings, and only exclusion criteria is to achieve the intended purpose in the pharmacological and immunological means. So there is a only exclusion criteria here. Can you move to the next slide? So medical device rule 2017 is implemented effective from 1st January 2018, as it is been designed and initiated from 31st Jan 2017. So the medical device rules tells the international regulation practices and provides a comprehensive legislation and regulations of medical devices for import, clinical trials, manufacturers, sales and distributions as per the IMDR, International Medical Device Regulatory Forum. And we are not part of the we are developed according to the international requirements. So medical device rule 2017 classify the medical devices based upon the list. Class A and Class B medical devices are low to moderate risk, regulated by through a state drug control department under the state government of India, governments of India. And Class C and Class D devices are moderate to high risk devices like ventilator, intraocular lenses, bone fixers in Class C, and cochlear implants, defibrillators, codex. These are some of the examples, which is available in detail around thousands of devices available in the CDSC website. Please refer the list of medical devices and associated it. Please move to next slide. So these are the other than medical device notification, these are the devices which is already under the regulation under the Drugs and Cosmetic Act 1940 and 1945, medical device rule, Drugs and Cosmetic Rules 1945. So these are all regulated as a drug. So these are all the assumptions given in the medical device rule. Can you move to next? So these are the regulatory agencies involved in the regulation of medical devices. In Class A and Class B or any of the class of medical devices, import or regulated by Central Licensing Authority. For manufacturing, State Drug Control Department will regulate Class C and Class B devices. For high-risk devices, Class C and Class D will be regulated by Central Regulatory Authority because it involves a lot of risk and a lot of evaluations involved. And the permission for conducting clinical trials exists only with the CDSU as a central licensing authority for sale of any product into the particular state. Even though if you got these approval for sale or distribution, we need to get approval from the corresponding state drug control department only. And the quality management system is being monitored to a notified body for a Class A and Class B devices, and Class C, Class D devices will be taken care by CDSU. So, due to time constraint, trying to move slide further, please. These are the medical device chapters. Due to time constraint, not explaining, but chapter 1 tells about the title, applications, and the condemnation and definitions. Class 2 tells about the classification of medical device by a group on each specialty. Class 3 tells about the authorities' powers and notification, notified bodies and testing facilities exist in country. And Class 4 tells about the manufacturer of medical device, appliance inspections, grant of license, conditions for license, suspension of license, and its associated forms will be explained. Class 5 tells about the import of medical device and its what is the permissions, grant of licenses, and how to use, what is the intended purpose, all will be listed in chapter 5. And chapter 6 tells about the labeling requirements, what are the conditions to be followed. And class 7 tells about the clinical investigation, like permissions, medical management, compensations, and inspections of medical device inspectors through the government medical manufacturing facilities and as well as the institutions. And we also class 8 talks about the permission to import or manufacture medical devices which does not have the predicate medical devices. Class 9 talks about the duties and powers of medical device officer and a medical device testing officers and a notified body. Class 10 talks about the regulation of laboratories for carrying out the test or evaluation. Class 11 talks about the sales of medical device. Class 12 talks about the other miscellaneous. Can you move next slide? Yes. This schedule talks about, first schedule talks about the classification of medical device and in vitro diagnosis kits. And schedule 2 tells about the fees structures. And schedule 3 talks about the regulation, registration and functioning of notified bodies. And schedule 4 talks about the product compliance such as document requirement for manufacturer or import license. The various forms are exist that will be done. Class 5 talks about the quality management system, like whether you want to follow IS 13485 standards and the required other standards for risk management and evaluation. Class 6 talks about the post-marketing, post-approval, what are the major and minor changes in case if anything exists. And class 7, schedule 7 talks about the requirements for conducting a clinical trial. Class 8 talks about the other assumptions. Next slide, please. So in the class 5, they explained about the compliance to the standard. So these are the ISO IE standards which need to be compliant. Can you move to the next slide? That is no, like ISO, how they standards, if you come to the standards, they explain about how the standards are in picture. So now ISO is a set of international organization for standards that have developed some sort of standards. They have to incorporate globally, so they aggregate the bodies at the regional level. So APAC is the Asia Pacific Aggregation Council, is the regulatory body for standardization body to give a standards for the region. They aggregate further the national bodies like IAS for US or NABCB for India, so on. NABL or some of the accreditation body, they are under the IAS. And we have another international organization called International Laboratory Accreditation or Cooperation, which gives a standard, prescribed standard for testing, calibration of laboratories and inspection bodies. So once this accreditation has been given by this institute at the national level, the national level accreditation bodies like NABCP will give us certification bodies to get do a testing calibration and I go for having an audit and give a recommendation manufacturer or a medtech companies to review their quality checks as per the requirement or not. So some of the examples are UCAS or even IPC. We are trying to get ICMED under the ICMED scheme. We are also trying to become a certified body. So it is in the process. Soon we can also be a certified body to give a certification. ICMED is developed jointly with NABCB, QCA and AABED. So that talks about the product and process, both the thing. So, but these standards talks about only the process. So BAS standards, in that rule we have said we need to follow the international standards. If that is existed, national level we have BAS standards, or we can also have industrial standards that need to be considered in case the manufacturer have unique. So if there is no such standard exists, the manufacturer can define their own set of standards and they can proceed further. So even though we have set some of standards we explained in NABCB as certifying this body, NABC, Quality Control of India is a Ministry of Industry Development and Promotion. We, along with the FCCI, they are out. There is a organization form which also have some other organizations like NABH for accreditation of hospitals and NABL for testing and calibration of laboratories and accreditation to a conformity assessment body because they are part of IA. They are accredited by IAF and NABED. You know, this accrediting the schools. Like we have some other like FSCI and so on, many of the so on many accreditation standards are there like this, and we also have a quality accreditation institutes and FDAS, or these are the two institutes apart from the, it's similar to NABL. It is a non-government private organization giving an accreditation for the organizations. Next slide, please. So, as you are aware, we are all familiar about JC and NABH. We are also have some other international bodies agreed with the hospitals and clinics. Please, next slide, please. These are the key definition. I don't want to touch in that to manage the time frame. This is self-explanatory. And these are the key comparison: medical device, IVDs, and drug. IVD medical devices are used in vitro or ex vitro, but IVDs are used in vitro only, the name says, and the drug is in vivo only. So medical devices are diagnostic or therapeutic intended use, or diagnostic IVDs is only for the diagnosis intended use, and drug is for a therapeutic intended use only. Medical devices are active component generally based on the mechanical, electrical, or material engineering, but IVDs deals with the antibodies and antigen based upon the test kit like pregnancy test kit, HIV test kit, so on. There are many examples, and drugs deals with the API or active pharmaceutical ingredients. Medical device deals with the performance of the device. Here, IVDs will be analyzed based upon the sensitivity and specificity. We should understand the false positive and false negative, and we should do the calculation accordingly. In the medical device, we have to have a clinical investigation for new medical device. In IVDs, we perform the clinical performance evaluation for the new devices, and drug we have a clinical trials. And in medical device, we have to analyze the stability studies in the real time and accreditation conditions. But in the IVDs, we have to have a real-time stability accreditation, in-use stability, transparent stability, so on. We need to assess what are the cause of failures and we can how to improve it. And in drug, we have to discuss about the stability studies in the real-time and accredited conditions. And medical devices will have a generally storage at the room temperature, yeah, apart from some misconceptions. But IV should be stored at 4 degrees to 8 degrees Celsius, and drugs should be stored in a general room temperature or some of the specific drugs according to the manufacturer instruction. Medical device can last for a longer shelf life, but IVD shall have a short shelf life, but drugs have a longer shelf life. Each are not unique and each are not cannot be regulated in the same way. So we have some challenge and we have to think on each case by case scenario and we have to work on it. The medical devices are regulated by central licensing authority and state license authority. Initially, they are given a voluntary timeline of 18 months and they are given a mandatory timeline of 12 months and 24 months for Class E and Class D devices. Now it is under the regulatory regime. So all the medical devices are regulated. Next slide, please. So these are the recent notifications. Whatever the notification happened in since medical device rule 2017, they are summarized in make a medical device rule 2020, and it clearly says all the medical devices are regulated under the medical device rules. Next slide, please. And even though the product is being tested in a clinical trial or a evaluation or then, even though if that is a product is in the market, it have a benefit and risk. Once we enjoy the benefit, we also have to minimize the risk. So there is a requirement to have a monitoring system, whether it is benefiting more or what are the risk exist and how to minimize it. And what are the necessary corrective action like corrective or preventive action or a root cause analysis to be done for taking the corrective or preventive action. And we should keep a monitoring system to comply about the received complaints and what is to be the monitoring. And it can be done by anyone, manufacturer, authorized agents, importer, distributors, consumers, healthcare professionals, anyone can report. Now it is an open platform. Next slide. The post-marketing surveillance is a systematic process of collecting and analyzing the information gained from medical device and IVDs. In case of new device, we have subsequent approval process and closely monitoring the system in place. Next slide, please. So this was a draft exist in the CDSU website, which talked about the post-marketing surveillance of IVDs, which is there for public comment. Still now it is not become a final version. Next slide, please. So these are the responsibilities of various parties and their roles. So end users can report the incidents through the manufacturing instructions. It's a self-explanatory and can move further if case if there is a time constraint. So these are the classification of adverse events can be determined as serious or moderate and mild adverse event. Serious adverse is like death or disabilities or any false negative results due to IBDs, or moderate risk of false positive reports that can result in misdiagnosis, or mild adverse events, any deficiencies found in the user before the use or adverse event caused by the device exceeding the shelf life, so on. And these are the some of the examples. Due to time constraint, I'm just skipping this. So these are the process. Who can report? As I defined, anyone can report. What is the reporting method? It can be reported through MEPI program, which is available. The reporting form is available in the IPC website. And timeline is for serious adverse events within the 5 days from the date of you came to our. For moderate incidents, you have to report by 30 days. And for all complaints, you can report within that timeline as early as possible, generally. No need to stick for the timeline. Try to report as early as possible. Where to report? To Indian Pharmacopoeia Commission or CDSEO, that is available in the web. So why to report this? Mandate through the program. This program is voluntary, but regulatory compliance with the manufacturer is mandatory. And we also insist through NABS 5th edition says the FMS 5G says that healthcare professionals should enroll, healthcare organizations should enroll and report. And NABS 3rd edition says about all the small hospitals should enroll and have a monitoring system in place. And to have a regulatory and corrective action, as we are 80% import dependent country, we should have alerts and product recalls from global regulators, and we should check our inventory whether such products exist in our facilities, and we should take any corrective action, or they can give us just a software update or replace a particular product. If we contact the OEM, they will replace and they provide the required services. How to report? We have medical device adverse events reporting form. It is for the previous slide, please. I'm just ending this there. Previous slide, please. Yes, we have medical device adverse events reporting form for reporting such incidents, and it is a 5-page to have a detailed assessment from the healthcare professional, manufacturer, and so on. And field safety corrective action form will talk about for the manufacturer in case if they have product distributed to the market and they found any corrective action and preventive action is required or it can be harmful. So they can withdraw through this form and they can communicate to the regulator. For the consumers is the champions over here. So they can report through PVPI mobile app or through a toll-free mobile app. We are also working with the AI and ML models to have a better reporting systems also. Next slide. So what is the reporting form? We have developed a single page consumer reporting form. What information you want? General information. Who is the reporter? What is the device of product? All the outer cover of the product will tell us about the manufacturer, importer, and what are the products, lot number, serial number, so on, and where this incident is happened. So if you give a detailed information as clear as possible, will help us to get back with you and get a clarity. Whatever the information is required, we can clarify forward. Next slide, please. And what we have done as of now under the material vigilance program, with the design fault with the EPIM plant, we have taken a thing and we have got, the patients got some 5 lakhs of compensation through particular EPIM plant. We also found the quality regulator in the insulin pumps so that that can be an overdosage or underdosage in the insulin delivery. And we also have exhaust of pacemaker. So pacemaker I'm ended. Two more slides.
Yeah, sir. We are exceeding more time.
These are the examples. So, yeah. Okay. Next slide, please.
Yeah.
So these are the lot and patch they monitor and how they will do the corrective and preventive action. Then next slides. So these are some of the case studies what we have alert issued through CDSEO, and we also have some surveillance monitoring alerts to the healthcare facility based upon the experience and data collected. Next slide. So material vigilance program overview, it is launched in 6 July 2015 by in Indian Pharmacopoeia Commission. Partners are Indian Pharmacopoeia Commission, Sri Regional Institute of Technology, NHSRC, CDSEO. We have 451 monitoring centers as of now, and another 150 are still on the way. And 895 ADR monitoring centers. We have established a good network. But next slide, sir. We are facing some sort of collecting the incidents. We need your awareness program like this to take it further. We request organizer to arrange a dedicated program so that we can get a better insights. Thanks a lot for giving the opportunity, and apologies for the delay.
No problem, Mr. Hariharan, and thank you for that comprehensive presentation. Even though I am a medical professional, I did not know much of what you spoke about, and this is extremely informative. I believe it deserves a special session with our patients and patient groups and community on educating them about the material vigilance program as well as the pharmacovigilance program of India. Much of this is not known to us. and it would be extremely useful. So we would certainly reach out to you for an expert session on this so that we have more time to discuss some of the questions that might come from the audience. So thank you so much
Thanks
for
a lot,
setting
ma'am.
that background on the regulatory landscape. And we now turn over to Dr. Ranjan Agrawal. And sir, considering that we have devices, we have the IVDs, we have the patient samples, we also have chemicals. It's a very complicated atmosphere. So what are some of the common errors that can happen in such a scenario? And how can patients be aware about this? And what can they learn? And what can professionals do to minimize those errors? So thank you so much for joining us, and over to you.
Okay. A very good morning to one and all, whoever are the participants and the organizers. And thank you for letting me in. And it's indeed a great effort, the way that you have put up different specialties together and the concept that you have come out. So the background has already been dealt with, especially by Dr. Ratna herself, followed by the regulatory bodies. I'll just like to give it into a sort of presentation. Definition wise, if we deal with what are the common diagnostic errors, we basically mean that these are common errors, but they are important as well because initially they have a chance of being preventable, preventing what? The mortality and the morbidity of patients, especially in different clinical conditions. So, summing them till they are preventable, it's okay. But the moment they reach a threshold above it, where they become or turn out into a harmful effects, they become problematic, not only for the medical professionals, but also from the patients, their relatives, and the people who are attending them. That there is a loss of life, either into a permanent disability in any way it is, or turning out into a final death of the patient. So the main target of the laboratories, and when I talk about laboratories or the diagnosticians, I include both the radiologists and the pathologists, the biochemists, the microbiologists. They all are into diagnosing a disease and telling that this is the disease and this is the treatment required. So during the course of my presentation, I'll be giving just a very few common examples which we are dealing with daily. So when we say that they have reached a threshold of the harmful effect, we especially mean there are three conditions. One is diagnosis of infections, diagnosis of vascular effects, and diagnosis of cancer. Now, the moment we have an infection in the patient and we are unable to diagnose, this infection keeps on increasing to such an extent that it becomes irreversible. Who is at fault? Obviously, the diagnosticians. When we deal with the vascular effect, okay, we have a bleeding, but it is not controlled. What normally we say in our household, just keep on pressing it for a prolonged time, it will be okay. But did we realize that it is not a small effect? It was supposed a hemophilia, which is a congenital disorder, a genetic disorder which needs a proper treatment, and that is factor A transfusion. You give factor A, the patient will be okay. Otherwise, you say whenever the child starts playing, there is a trauma and the bleeding does not stop. As the child keeps on growing, the vitamin A requirement keeps on increasing, and this is a recurrent problem. Had you gone into a specialized test, it would have been diagnosed. Most important is diagnosis of cancer. Cancer means a malignant condition where the patient's life and death is at stake. We, in a normal term, in medical term, we say cancer or a tumor or a neoplasia. Now, if it is a simple one, a benign, we classify into two for everybody who is participating. Simple tumors are known as benign. The one that have a tendency to spread from one area to different areas is known as a cancer. Obviously, we all know cancer is very harmful, and the moment you diagnose, you start we all watch movies, and what is the first thing that we ask? Doctor Sahab, how much is the time left for my patient? This is a very common question that is often asked to a pathologist also. Sir, how is the severity of this tumor that you have diagnosed? So we need to say It is grade 1, grade 2, grade 3. Grade 1 means, okay, there is a prolonged life. Grade 3 means it is very severe. So, now, when we deal with a common diagnostic error, there are three terms which are very overlapping amongst each other, but they need to be reported cautiously. One is a delayed diagnosis, a wrong diagnosis, or a missed out diagnosis. When we look or hear these terms, it is very clear, okay, they are quite overlapping. But actually, what it is, if it is a delayed one, okay, one test you do, second you do, third you do, by the time you arrive at a final diagnosis, it has been quite a prolonged period of time and it is delayed. A wrong diagnosis, where due to any fault or due to misinterpretation, you have made a wrong diagnosis. Third is a misdiagnosis, where the thing is right under your nose, but you are unable to diagnose it. Quite overlapping, but they all are important in their own meaning. So, what do we actually aim or target at? A right diagnosis made in the right time with using the right method. And obviously, if it's a developing country, we need to say cost-effective method of diagnosis. Now, there are certain contributing factors which lead to these common diagnostic errors. What are these? The first and foremost is human error. Now, what is common in the present scenario? The first thing is people are into their mobiles, right? So, like while I'm just talking to you, I'm concentrating on this webinar. Do you actually think that I'll be able to do justice to this webinar? No. Similarly, while we are into this, any type of diagnostic thing, and the first thing is, I mean, you're putting this and this one mobile in the left ear, one in the right ear, and you are reporting also. So these are human errors. Then you have technical failure. This includes multiple things. Then there could be failure related to the proper medical condition of the patient. So in whenever we are medicos, the first and foremost thing we are taught is take a proper history of the patient. Now in this, especially after the COVID period, we have a tendency of, okay, the patient is very far off and you do a remote type of counseling or a consultation. That should never be done. Because suppose you have a spot on your cheek. Simultaneously, you have another spot right in your extremities. The diagnosis changes. So a proper history with a proper examination of the patient is mandatory, and then we can keep on doing it. Now, as a laboratory diagnostician, machine error contributes to good amount of diagnostic error. This means, like I'll give you a very common example. We are using automated machines. In this automated machine, if the sample volume is quite low, so there are chances that there would be errors, especially if there is an air bubble in it, you see your values are overshooting. So these are common problems which we normally face. And then this is the role of the laboratorician or the diagnostician who is seeing and interpreting the things. Then you need to do some certain collaborations. Like if your creatinine is very high, you look that why is the urea not rising? If your urea is high, you correlate, okay, the creatinine should also be high. Otherwise, you diagnose whether it's a liver function disorder or a renal disorder. Then certain diagnostic errors which keep on coming up. Now, actually, this is a tip of an iceberg which is there. Tip above the iceberg or the thing that is visible is just the preventable. But the majority chunk is below the ocean level or the sea level, which you cannot prevent and which is doing a slow damage to your body, and just because you have missed or wrongly diagnosed a patient. I'll just quickly go through 2 or 3 very common examples. Recently, we had a great pandemic that was COVID. And what was the presenting symptom? Everybody near you was coughing or a fever. Now, this coughing, do you need every patient? Does it mean that every patient has COVID? No. It could be a chronic obstructive pulmonary disease. It could be tuberculosis. It could be a tumor in your lung. and obviously COVID. Now, these are vast spectrum of diseases which need to be covered up. You put in a test and you diagnose. For COVID, you have a simple RT-PCR. You see it, report it, and then yes, okay, COVID positive. For tuberculosis, you go in for a sputum analysis and you diagnose it. Second, very common is a sort of heaviness in your chest. Normally, what we do, there is something heaviness in my feet. Commonest cause, myocardial infarction, which in a layman's language, we say to be heart attack, or a gastric indigestion, acid indigestion, right? You go in for a simple test, ECG, you find certain wave changes, or an echocardiography, you diagnose it, right? So these are smaller problems which you can diagnose. More common, like UTI versus pyelonephritis, pneumonias, cancer we have already seen, hypertension, osteomyelitis. Now this osteomyelitis means there is an infection in your bone. The moment you diagnose osteomyelitis through a radiology or in pathology, any type of thing, then what do? This becomes a source of infection for the entire body. You diagnose it delayed, this will keep on spreading and your entire skeleton system will be affected. So the main target, I'll summarize it. The main target is differentiating between the preventable and the non-preventable diseases. So just by knowing what common diagnostic errors we can encounter or are likely to encounter, you can prevent a lot number of mortality and morbidity. Morbidity is a disease. Mortality means your death. So I again thank the organizers for letting me in and giving me an opportunity. And I hope I did justice to the topic. Any questions? I would be most happy to answer that.
Thank you, sir. We do have a few questions that we'll take after our last speaker. And
Okay.
you actually put that in a very simplistic manner by categorizing it into delayed.
Actually, because of some casualty in my house, I could not prepare the PowerPoints,
No problem,
and
sir.
I was have to. But
Yeah,
I thought I will
but
be
it
putting
was
it.
quite clear and very enriching and enlightening, and also the complexity of the whole diagnostic landscape makes it
Yes.
very difficult um, to be always correct. Also, we do not have the healthcare systems where we have electronic health records so that you have
Right.
longitudinal data. Given this landscape and given the environment that we are working in, diagnostic errors and delayed diagnosis is quite common. Because data is not shared across hospitals and across physicians.
Normally, it is hidden.
Normally,
Why will I tell everybody that I made a mistake? But
yes.
the moment we start committing to this, at least the fellow colleagues and I myself not be repeating the same mistake again and again.
Yes, and also it will reduce the healthcare costs for the patient in the long run, because early diagnosis will mean that they receive the appropriate treatment as soon
Perfect.
as possible.
And that is what is our target for.
That is what every physician wants, the best health for their patient. So thank you so much. And as I said before, I think this topic deserves more discussion and more exposure and awareness for patients, patient groups, communities, as well as professionals. So thank you so much for joining us today, and we will certainly reach out to you again for further sessions. And now, given the two backgrounds that we have, where we heard about the regulatory landscape and the challenges for collecting data, as well as for the environment in which we are working and why diagnostic errors happen, including delay in diagnosis or misdiagnosis. We will now turn to our third speaker, Dr. Vikram Singh, who will talk about the impact of these diagnostic errors, both on patients, on the economics of healthcare, as well as the general profession, and why it is important that we minimize these errors because of the cost of missing a diagnosis or a delayed diagnosis to patients and families. So over to you, Dr. Vikram Singh, and thank you so much for joining us today.
Yeah, thank you so much, ma'am. Am I audible?
Yes, sir, you are.
Yeah, thank you so much. And as already this already has been discussed, Dr. Ranjan, and like the previous speaker, so a lot of the things has been discussed about the diagnostic and relevant access. So my job is like is easier as compared to with the previous one, because ultimately as we all are aware that the diagnostic play a vital role in each and every aspect. Fine. Without the diagnosis, either we cannot treat or prevent or manage any of the disease or illness. Fine. So as I have a background of the diagnostic as well as into be the treatment as well as the education. So different diversions I have just looked it out, and I can also just share my experience as well. So can you please just share the PPTs into the, can you change it please?
Yeah.
Yeah.
I think it's visible, sir.
Yeah, yes. Now it's visual. So diagnostic error that is play like a wider role into the like as getting the wrong misinterpretations as well as this the death rate also been increasing due to the diagnostic error as well. So it's resulting in the human and economic cost and increasing day by day. So misdiagnosis can lead to the patient harm and increase the healthcare expenses widely. And for the but a point of view of this diagnostic that how it can be reduced. So electronic health record nowadays, every hospital is just engaging and in the low resource settings. Additionally, it's also be just increasing every day. Fine. So there are the two major factors which are impacting, that is the human cost as well as the economic cost. Can you just please move the slide, or can you give the command on to so I can share my PPT, please? So that will be easier. Okay, sir.
Yes, sir.
Yeah. Can I share my PPT? You can just stop this. I can share.
Sure,
And
sure.
I will manage. Yeah.
Yeah.
Thank you. I have PPT can visible.
Yes, sir.
Yeah. So there are the human cost. Yeah. The human cost that particular diagnostic error dramatically alter the course of the treatment and patient outcome. For instance, like a misdiagnosis condition may lead to the unnecessary medications and the severe side effects as well. If you take the example, if the patient is diagnosed with the dengue, fine, and maybe he has also with the comorbidity or maybe some of the aspect, fine. So doctor are advising some of the medications which may not exactly the ultimately into one to another, but again it's like the increment of this cost as well as to the psychological impact can also be varied, and it can also be leading to be certain health issues. So because if the diagnosis is not correct, then economical cost we usually face, and the cost associated with the diagnostic, it include not only to be the like the saving, but also the health insurance. There are the different aspects that the people are misusing it. For example, I have taken my personal experience in one of my, like as the neighborhood, the person who do not have such of the element of the cardiac, fine, have a symptom of this high BP, but for only sake of the policy is to be like as to get benefited. So he admitted for the shorter time, fine, and lot of the expenses has been increased, and again it going to be the negative impact and ultimately increasing the variations on it. Fine. So there are the various contributing factors in these errors, as already sir has been discussed. These are systemic failure, communication breakdown as well. If you talk about systematic failure, so like it's encompass wide range of the issues like technicality, like the electronic health, data management. But nowadays it's managing as compared to the earlier one. Earlier one, there are a lot of the like the issues, but almost nowadays the hospitals are managing it. But again, the technical error can also be come here. Fine. Next is the communication breakdown. That is the effective communication, very, very important in all the aspect. Fine. And misunderstanding between the healthcare provider and the patient barriers can also be the impacted. How it's like as maybe the test interpretation is not so valid. Maybe one of the result is varied due to any of the circumstances. fine. And if the result is not too good, and the communication with the technical person to the pathologist to be the physician, then again it's kind of leading to be a lot of this again challenges. Fine. If you look for the cognitive bias, that the healthcare providers may influence their subjective experience, leading to the cognitive bias that affect the diagnostic accuracy as well. And recognizing the mitigation through biases can also be just take care of. Fine. So, and as in India, as you are aware that the lot of the diagnostic centers in the remote areas, with the quality they are not maintaining too much. Fine. So they are not competing with the Dr. Lal or maybe to the other reputed organizations to compete or like as to compare their results, but they are giving the results. And again, and many times I have seen in the local areas that either the test is not performed, they just give the result. Fine. Okay. They ask the patient, okay, what are you feeling this? Okay, fever. Just okay. They will increase the TLC somehow. Fine. And like the ESR is somehow, and maybe if the female is, then they will down the hemoglobin, the lower one. Fine. So again, maybe the patient is having some of the other like associated diseases, or you can say the some of the other issues, but exactly the proper diagnosis is not yet done, and that again impact into the severity of the cases. Then the case, then these patient got difficulties, and might they will transfer to the tertiary care hospital again. Might be there are a lot of the issues that many times they lost their life. Fine. So that can be the one of the issues into the remote areas. The quality is not maintained properly in the diagnostics, which I just personally experience into with one or the other. So how we can strategize these ones? So improving diagnostic accuracy require a multi-phase approach ultimately, that we need to be electrical visibility of the data, and it need to streamline. For example, there should be a regulation for the laboratories. Earlier there is no like the so much of the regulations in the laboratory, but as the Allied Health Council is coming up within a year or 2 year, so mostly the regulation in the laboratories also be into the reported, and only limited laboratories should be there, and they need to be verified the result with these like the you can say the high quality check. Fine. And uh, that ensuring the interpreter access as well, like providing access to the qualified like the person, so the other persons can also be check the result. Fine. They can interpret one to another. Fine. Then addressing the social determinants, if and then the effort to be improve the care access for the affordability and undeserved communication that can mitigate some of the system error and to the reduce the chances of the error. Fine. And very important is the education. Like as the technician, they should be well like as particularly educated as well as technically sound. Many times we have seen on the academic settings as well, the student do not have too much of this knowledge of the theoretical, but practically once they will do in the 1 and 2 months, they usually feel okay, we are very confident we can perform the test, but the technically behind of the concept might be not so much clear. Fine. So for that, what we can do a session of this professional development into the training time. It should be like a monthly or the weekly for upgradation, and there should be a supervisor on that, so they can evaluate that what they are doing exactly. Fine. Usually the pathologists blindly trust on the technician that okay, whatever the result they will give, okay, it will be acceptable. Fine. But it should be need to cross check many times by the concept maybe and the clearing one to another, and whatever the issues in respect to be the result, it need to be taken care seriously. Fine. A lot of the cases has been come up if we talk about this delay in the diagnosis or misdiagnosis. Fine. And one of the case I found like the endometriosis a common and commonly missed in the delay diagnosis. Fine. So that is the case. A 15-year-old girl who not prior medical problem developed disability, menstrual cramps, and having the bleeding at the onset of the first menstrual period. And she immediately sought care from the gynecologist who started her on the oral contraceptive pills to manage her symptoms, which were attributed to be the bad period. So over the next 3 years, her dysmenorrhea continued and she developed the severe abdominal cramps, bloating, nausea, and again getting some of the difficulties. And she saw her primary care provider her severe diarrhea and was diagnosed with the IBS. So no additional diagnostic testing were pursued at the time, and she pursued a second opinion for another gynecologist to attribute to the symptom of the bad periods, and without having conducted additional testing on that. So a subsequent year of the 9 years, and her severity became too much, and then she was referred to the another gynecologist specialist, and specially perform a colonoscopy and shows her only the like the bowel, particularly what is associated with that. So again in the year they experience of right abdominal pain, and see an urgent computer tomograph scan which are interpreted showing the acute appendicitis. Fine. Then after the post-operative appointment, surgeon informed that her to procedure and prolonged due to the endometrial lesion close to be the appendix. Then patient was informed that the lesion caused by the appendix to became the infected. Then surgeon did not call to the cardiologist surgeons, and again it can be like as he was did not remove one of the suspected endometriosis here. And once the diagnosis was made by the several surgeons, the patient continued to be the experience delay into the accessing appropriate treatment due to the medical insurance coverage. Fine. Then here will also be the coverage of the medical is just interpreting the result. So ultimately, the patient underwent a diagnostic laparoscopy to confirm the endometriosis by the biopsy, definitive surgery, laparoscopy via the field of the excision of the endometriosis, and performed the 12 year after how the symptoms started. So all these things the patient fell, and the point that her physician had implied that severity of symptoms was due to the mental health condition, and she stated thorough that this time her symptoms were often dismissed and psychological. She was made and feel that she was so crazy, and like as without a strong advocacy to be like the parent, once she felt the physician would not have pursue additional diagnostic testing. In fact, so usually the patient feel like as the treatment is not too much and they don't rely, because a lot of the unnecessary diagnoses are nowadays, I mean, which are just increasing the cost to be the like the patient as well as to the economic like as wasting of the things is fine. Whatever the thing is required due to I feel that it should be the most appropriate as the person is. Otherwise, it's misleading to be the core of the diagnostic point of fine. So in the end, if I summarize, so like as the diagnostic play a wider role, but it again if it's not maintained proper or regulated, fine, into the laboratory basis as well as maybe on to be the interpretation into the clinical side and on the like insurance coverage. So all these are factors which may be in tackled, and if smoothly run into the regulations, then definitely we can tackle out with the monitoring aspects as well. So I hope it is my opinion only, and as the expert, you have so much of the experience on it. But I think the only the limited diagnosis, which is so accurate and qualityful, we need to be like as address, and it should be like as good for the common people, and whatever the necessary is, it should not be missed. Thank you so much for giving this opportunity.
Thank
And
you.
if any questions, then I will happy to take it. Thank you.
Thank you. Thank you, Dr. Vikram Singh, and thank you for that example that really exemplifies why a delayed diagnosis could cost so much, not only cost extra, investment in terms of healthcare for the patient, but also cost so much of mental and psychological trauma to the patient, and why timely diagnosis is important. It also brings forth the fact that usually treatments are multidisciplinary, and unless physicians work as teams, and patient records are available to all physicians, delay in diagnosis might happen, and therefore that might cause harm to the patient. So thank you for that presentation.
Thank you.
I had a few questions, and my first question is to Mr. Hari. So you said that we are 80% import dependent as far as devices are concerned. And the fact remains that, even though we have a very strong regulatory mechanism in the country, it is very hard for people who are buying these devices to know whether those have qualified and have passed the regulatory requirements. And how can a commoner on the street verify whether they are buying an instrument very simple like a BP, a blood pressure monitor, is actually compliant to the regulatory standards, and what should they look out for when they are buying such instruments? Because many a times patients take their medications based on what they see when they are monitoring themselves or checking for their own, hemoglobin, or for their blood pressure, or for their say for simple use of glucometers and their blood glucose levels. So how can they ensure that whatever they are buying is certified and validated by the regulator?
Ma'am, I like to classify this into various points for a better understanding. First is what are the medical equipments or device we use which need to have a preventive maintenance calibration on a regular basis based upon the risk or how it is impact. So for OCD devices, we are not doing it. So that can have an accuracy range of 15 to 20%. That is not a final thing. That first awareness is required, and you should get calibrated with the masters, or you have to cross check your BPE with your normal conditions or with others to have understanding how much it is deviating from the normal. Second, we should have some establish the calibration facilities, or the manufacturer should come up voluntarily to do that thing. We even found one of the incident like glucometer, it is being reported. And when I go and argue with the vendor, they are telling like they are giving ISO standard that it can have 15% deviation. So with the glucometer with 15% deviation, they are defining that they are correct with the ISO standard. They are defining, they are claiming it. So that is not at all acceptable to the clinical. They should improve their specificity and specificity. That is the another challenge over here. Even though we have the regulatory systems, it is budding now, and we are going to a progressive state, but we cannot have a full control until the consumer awareness is there. We have a risk management through ISO 13497, which says we have to classify the risk and we should transfer the risk. So we should have a first practice of reading the instruction or instruction for use or user manual, how and what to use and what is the do's and don'ts. That we first lacks. That's all the things will help you. The user manual, we can put the regulation into the user manual. Usage is lies with the user.
Thank
So
you.
I request the end users to go through the user manual and get a clarity what is to be done, what is not to be done, and how to report.
Thank you. That actually raises a question on whether the user manual is user friendly, meaning it is in a language which the user can understand. So it has to be user friendly. It has to be in multiple languages so that people are able to understand what the device is meant to do and whether it has an expiry date and whether you should replace that instrument after a certain use. None of this is usually available or understood by patients, and that is the reason why a lot of times patients face problems because they think they are doing their monitoring well, but they are actually not doing it.
And all the regulatory informations are available in the country's regulatory websites. It is an open platform. They can Google it. We are Googling thousands of things. We can Google and search whether it has anything issues.
So would there be a list of all the approved devices in your platform?
In CDS website, it is listed because they are the regulatory body. And as we are 80% import dependent, the USFDA or other, they are maintaining a MODA database, UDA database. You can put your device, what is their adverse events, or whether your product is having recall or any alert exists.
Thank you.
Recently, BPAP CPAP machine has been taken, and we are taking necessary corrective actions at this.
Thank you, Mr. Hariharan. Dr. Agrawal, I had a very simple question to you. In a diagnostic setting, which is well calibrated, run by teams, it's quite easy to control the quality. But we are moving more and more towards point of care diagnostics, where patients want the control within their own hands to be able to have an early diagnosis or have maybe regular monitoring. Given that the conditions in which these point of care diagnostics are used is not under the control, meaning in terms of humidity, environment, storage conditions, etc., what consumer education or what patient education is required to help them to understand whether their diagnostic parameters are not correct and when they should come to a lab if they feel that something is not right?
In conjunction to question one, patients should very clearly understand that these POCT, point of care instruments, they are screening instruments.
Yeah.
They're not diagnostic instruments, number one.
Right.
This means that you can just regulate your sugar for a few moments, for few time. What it should be interpreted is, okay, today my sugar is high, sugar is low. Just if we take an example of a glucometer, but the reading that is coming there should not be taken as the final reading. Number one. See, there has to be a scientific reason to this. A laboratory takes blood from the cubital vein.
Yes.
whereas this glucometer takes blood from either from the capillaries. Capillaries have a 15 to 20% higher sugar level than in the vein. Simple logic. So if your actual reading is 100, this means your glucometer will give you 120. You take your glucose level as 120 and you take it as a final one. You have taken a higher insulin level or an oral hypoglycemic. This means what? You will have a higher chance of getting hypoglycemic, and then you will blame somebody or the other. Second point is that these instruments need to be calibrated. For calibration, obviously these ISO certifications, etc., they are there. But the simplest rule that I tell my patients is you bring your instrument to the laboratory. The same moment while we are taking out blood, you put a drop on your glucometer and test it. See the difference and then keep it in your records for at least 15 to 20 days till you come on your next visit. That this is my actual reading in the laboratory and this is the reading my glucometer is giving. So you can calculate the percentage of difference and that should be taken as a point of control or an internal quality control or a semi-external quality type of control.
Thank you, sir. A follow-up question. Nowadays, we receive most of our reports through an email or through an app. Given that data is available easily and can be accessed by people other than the patient or the consumer himself, how do we maintain patient privacy and ensure that patient's data is not misused? And this question is asked by Mr. Ajay Tomar from the India.
Yeah, I saw that question. I thought of answering that.
Yes, sir.
See, basically, it is upon the patient how, or the people, how they want their data to be shared or not. So if you remember that while they're filling up, any laboratory is filling a form, there is a consent or a permission to be shared or not. And we easily do it, thinking what? That why to get the trouble of going 5-10 kilometers and collecting the report when it is easily available.
Yeah.
Second point is the patients or the people themselves, they do it. They send this report very easily. They forward it on their WhatsApp to 5 different people.
That's true.
Somebody said, okay, you are pretty okay. Second person says you are borderline positive. Second says you take this. The third says you take this. And the fifth says something else. Now, with this khichdi that we call it in Hindi, this mixture of advices the patient follows and is at problem. So this depends. Now, this data is now with me. This is not my patient. This is nothing, but I got the data. Now I use this data and put it in across to somebody else. So is this not wrong?
It is.
So who has given the consent? It is the patient or the people who have given the consent. So we actually are ourselves own responsibility. Similarly, like a cyber crime, we give it while we at 20-30 points and at the end, okay, tick, 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 and then, okay, give a permission. We share the OTP also, and then we lodge a complaint that, yes, we have undergone a cyber crime. So I think that's the answer to what pertinent question that you have raised.
Thank you, sir. And that gives me an opportunity to ask Mr. Vikram Singh, given the scenario that we just saw, about sharing the data indiscriminately and patients not being aware that sharing data like this over social media platforms could actually land them in trouble. What kind of awareness and training sessions should patients as well as professionals, sometimes even professionals, share data amongst themselves? I know that as a physician community, we do share patient records to ask for opinions. So what should we do to raise awareness and build capacities of physicians as well as patients and communities to understand the problems that this kind of sharing of data could bring?
Yeah, that's a very, very important question. If you look for the healthcare industry, like as one of the session is the counseling session, it there, like as maybe the patient was once they will come. So first of all, there should be some video interaction that how your data can be like misused, maybe by the healthcare professional, maybe the other person, how it can be taken and how it can be like as misused. Fine. So there should be a proper like as mass awareness in the sense like the video once they are coming for the spending a short time, then it can be done to the hospital or maybe clinic side, fine. And once they have some of the queries or maybe some of the session taken care by the counselor, maybe the health educator, fine, and simply to be the okay, you need to be save your data. So at least a brief introduction, a brief background should given to that. If you look for this like a professional point of view, then for like professional development programs or maybe the session, maybe monthly or weekly or maybe like a quarterly, it can be done. So at least the peoples are going on that one. Or maybe as an healthcare professional or maybe some other aspect, then we can provide, we can just prepare some of the videos and it can be shared to the public, because now every person is using the YouTube, fine. So we can easily share on the WhatsApp. If they can, it should be short, like maybe minute or 2 minutes with the some of the graphical representation, what can the data, and it should be from the authentic or like the resources, like it's from the government side or maybe regulatory side. So the people will be aware on it. And as the lot of the advertisement is going into be the television, so one of the sort like as the advertisement can also be run up, so the people will be aware, either the journal or maybe the healthcare professional or maybe other aspect professional. So I think so by approaching this approach, this strategies, somehow the people will be aware and ultimate the decision on their own that what they want to like as implement and how they can be safer, that one.
True.
Because sometimes the people do not bother. Okay, I do not care. Okay, I have a limited amount in my like as the bank. If it look for the common people, so okay, I will do that. There is no issue, and mental or you can say the counseling should be done on that one.
Thank you. Thank you so much. And actually, that's a big issue. People are worried about finances, but not about their health data.
Yes.
So I think a lot of awareness needs to be done. And that brings us to the end of our today's session. So thank you so much to all our speakers and panelists who joined us today. Thank you, Mr. V. Hariharan. Thank you, Dr. Ranjan Agarwal. And thank you, Dr. Vikram Singh. It was a pleasure to host you. And we look forward to being connected with you again, because as I said earlier, in my opening session, we have a series of 6 webinars, and we would like to work more collaboratively to raise awareness around this very important topic that is very seldom discussed in most seminars or workshops. And this is an area that would require a lot of attention and focus, so that we reduce diagnostic errors and reduce delay in diagnosis and help patients get healthcare when they need it in the best quality and in the most safest environment. So thank you so much once again, and have a
Thank you so much, ma'am.
Thank you. Thank you, everyone.
Thank you, Keshav. Thank you, team.
Thank you.
Thank you all.
Thank you.
Thanks a lot for.
Thank you, sir. Thank
Thank
you.
you so
Thanks
much.
a lot. Have a nice day.